Well, good evening to you all, and welcome to our medical town hall this evening. We've had fun this summer with virtual medical town halls, and some of you have been part of our live town halls where we can answer questions so easily. I am a retired internist. I'm your moderator tonight. Questions are going to come to my computer, and I'm sorry, I am off screen right now, so you can see our guests this evening. Dr. Kriesman and Dr. Hardy are going to have a conversation about your questions, dialogue, and exploration. They are both primary care physicians, active in practice, open for new patients, eager, knowledgeable, and I will take your questions, but you're going to have to hit that chat button and then type. It'll come to me, and I will write them down, flow them in, and keep them active and interested for you. So, beginning right now, I'm going to turn it over to our two guests and let them introduce themselves. And here we go. First.
My name's Dr. Rebecca Kriesman. I just completed my first year of practice out in Muskogee. I am in a clinic right now by myself across the street from the Muskogee Hospital. I was born in Colorado, grew up in Norman, went to OU for undergraduate, OSU for medical school, OSU for residency, and now loving growing my practice out in Muskogee.
Wonderful. Brad Hardy, Dr. Brad Hardy, native of Tulsa, Oklahoma. Grew up here, went to Jenks for high school, OU for undergrad, OSU for medical school, followed by residency completion in 2016 and family practice. Since then, I've been at St. Francis, going into my 6th calendar year. It's hard to believe it's been that long, but starting my 6th year this July. I have 2 boys, 5 and 2, Max and Wyatt, and a wife. Practice out at St. Francis, wife Laura. Practice out at St. Francis South. Have a pretty fast-growing practice, and have very much enjoyed my time here. St. Francis has been immensely helpful, from the facilities to the specialists. Really, I could not have dreamed of a better practice situation.
Well, the path to this level of professionalism is not easy. Many decisions along the way. You both chose primary care. So what is primary care? Why did you walk this path?
Okay. Primary care is essentially a broad kind of catch-all phrase for a variety of actual specialties, including family medicine, internal medicine, pediatrics, and obstetrics and gynecology. People kind of use that phrase primary care and throw it out there to lump everybody all together, essentially who are not specialists, such as cardiologists or orthopedic surgeons. But really, there are differentiators between the 3, or 4 rather. As far as my particular path and why I chose family practice, I'm actually a 3rd-generation family practice physician here in Tulsa, Oklahoma. I take care of patients that were my grandfathers, as well as patients that my father delivered. When it's all said and done, if I give this 30 years, I will have taken care of 100 years of Tulsa patients. So that's pretty cool. And that's kind of why I went into this specialty.
So primary care for me is trying to be the entry into medicine to help with overall health and preventative care. I chose family medicine as part of primary care because I like a little bit of everything. I like taking care of newborns, I like women's health, I like working with cardiology patients and a bit of endocrinology and all of it together to try to make people healthy from an intro and get them to all the specialists they need to. Full practice, true primary care, true family medicine is what drew me to being out in Muskogee as well.
And that's one thing that I'd like to kind of follow up on, is just with several, or with specialties, it always surprises me that somebody can spend their entire career focusing on something so small as the eyeball, or even go further than that and be a retinal surgeon. to me, that just doesn't sound interesting, and it sounds like you're definitely pigeonholed after, 8 years of postgraduate training, getting that fellowship certification. Having that impact and those long-lasting relationships with individuals and being able to kind of facilitate healthy lifestyle changes through the years is just incredibly important.
And seeing people from their grandparents, the parents, the
Mhm.
kids, the grandkids, and seeing 3, 4, or 5 generations of one family at the same time, it's also pretty special.
Yeah, there just aren't many. I mean, you don't see that with cardiology or endocrinology. It just doesn't really happen.
So you're really talking about relationship, it's almost like a personal physician.
100%. I mean, I know my patients on a first name basis. They still call me Dr. Hardy. Some of them call me Brad, but it's definitely a relationship, and it's something that doesn't happen overnight. There's good fits and there's bad fits. There's patients who I'm sure move on and only see me once, but those that stay, I know are staying for a reason, and it's a relationship.
So primary care, you're both on this path, lovely, lovely stories. Personal care, kind of a quarterbacking care too, as you say, Rebecca, guiding into the system, kind of staying with the patient in the middle, being the hub with them in this world of swimming specialists. So it's nice to hear, because I've dealt with wonderful people who have 7 or 8 different doctors. And boy, we need the hub, we need the quarterback. How is communication with patients a little different in primary care?
Taking care of every aspect of the patient. So you're taking care of their mental health, their physical health, their developmental health, all at the same time. So you have to build an open communication with your patient where they're comfortable talking to you about every aspect of their well-being. It's not just a physical health or a chemistry health, it's every aspect of.
Following up on that, it's surprising to me how, when I see patients, they'll go and they'll say that they saw a specialist, or that not within St. Francis, and I'm not talking about any particular physician, saw a specialist who didn't look up at them once from the computer screen. That just blows my mind that we've lost that touch, that humanity associated with medical care and developing those relationships and having a communication. I never take it for granted when a patient comes in and is willing to essentially cry to somebody for the first time and let them share an aspect of their life that they haven't let anybody else see. It's very eye-opening, and it's something that I don't feel like we as family practice doctors ever take for granted, where some other physicians, some specialists might say, that's not really my problem. I'm not going to touch that today.
You both mentioned talking.
Mm-hmm.
Talking so the patient can hear you, talking so the patient can listen, and listening so the patient can talk. Sometimes listening is the hardest when you're busy. So you mentioned anxiety, stress, people talking to you. We've been in a pandemic, and I know it's affected the joys and sorrows all through our community, and how it's affected mothers and fathers. Rebecca, you were talking about that a little earlier. You want to continue about what are you seeing in the lives and hearts and thoughts and emotions of people?
So with going into a year and a half of dealing with a global pandemic, it's not been easy. I would say there's no one I talk to that feels no effect from the pandemic. It has been stressful and anxiety causing. It causes rifts in families. It causes long-term effects, long-term relationship trauma. And I don't think patients realize how it's affecting everybody. It's not just them.
It's been a horrible year. I mean, I'm just going to go ahead and say it, or horrible year and a half. For a while it seemed like there was light at the end of the tunnel, but unfortunately that we might not be there yet.
Yeah.
Not a day goes by that I don't see somebody, and this is nearly true for the entire past year and a half. I don't see a patient for anxiety and depression related to COVID-19. And that's just eye-opening. There was a period of time in January through probably April of last year, I had 2 to 3 patients on my schedule out of the 24 that I see a day who are wanting to talk about starting an SSRI or starting something to help with anxiety or depression. Because it's just, we as humans are used to social contacts and giving hugs and seeing each other's faces and just being around each other and sharing humanity, where right now we're still just living day to day. There's uncertainty, there's challenges, there's deaths, there's hospitalizations. I mean, it's just very scary, and that uncertainty is very hard for us to process.
I've heard that there's even kind of a new syndrome called touch deficiency, that none of us are getting enough of what we really need. What about parenting problems, Rebecca?
I've seen, especially with school coming back into session, I've had several parents even this week bring up the kid had a panic attack going to school because not everyone at school was wearing a mask. Not everyone at school was comfortable touching other people, or they wanted to touch them and the kid didn't want to be touched, and the parents don't know how to talk to their kids about this, and they don't know how to explain this to someone, especially in kids that have been either out of school, doing virtual school, and it's very stressful on the parents and the kids. The parents are worried about the kids going to school, the kids are worried about being at school.
I have a 2-year-old son who's turning 2 here next month. For essentially the entirety of his life, he didn't know what it was like to be a part of the outside world. He didn't know what it was like to see, aside from close family and our bubble, what it was like to be out in the community, to see people, to go to the grocery store, to go to the aquarium, to go to the zoo, to do these experiences that are just innate and so much a part of being a child. It's just devastating for myself and my wife, knowing that he wasn't able to have those things, as well as knowing that this isn't something solely isolated to us. This is something that's across the spectrum. I mean, all my friends who are parents, they're going through the exact same thing. Do we send our kids to school? Do we get them vaccines? It's just, the list goes on. I mean, it's a daily occurrence as far as questioning the overall health and welfare of your child. It's just very hard.
Well, you opened the door. You said the word vaccine and the word question. So
I'll take this one. I don't think there is a question. That's my perspective, and I can tell you that within the St. Francis Health System, greater than 98% of our physicians have been vaccinated. As far as the medical community, there's no reason not to get vaccinated. That is my opinion. I am a man of science. I read journals. I read real news. But again, it is a personal choice, and we are a society based on, essentially being able to make your own decisions and informed consent. So while we can't force this on anybody, I will say that the best thing to mitigate risk for COVID is getting a vaccine. My grandmother died in January of this year related to COVID-19, and she was a month away from getting a vaccine. It's just heartbreaking that she died alone. It's hard.
That was said very
Yeah.
well.
Yeah.
I second everything that he said. I also stand by vaccines. I strongly support and encourage them. And even a step farther than that, for anyone that's having a hard time talking to their family members about getting vaccinated, there are resources through the CDC website on how to talk to your family members about getting vaccinated, how to find the research and the science that all physicians are supporting. So it is out there and available for you, and talk to your primary care doctor about it. It's what I do all day right now.
stfrancis.com/get vaccinated.
I'll throw in my personal feeling, which is I follow a decision process by consensus. So I am interested in not a one voice or two voices, but Mayo Clinic's voice. So I went to the Mayo Clinic website again today. It's very interesting, their thoughts on outpatient therapy, what's available, inpatient therapy. And thinking of therapy, What's your experience with the pandemic of folks who didn't have their surgery, got delayed in getting something done, or maybe had a medical problem down in Muskogee and we couldn't get the help we needed? What's happening there with your experience?
So over the last year, we're currently,
Yeah.
over the last year, a lot of people delayed on purpose, things that could be delayed. 6 months, the last 6 months, people have been getting those procedures done. Hospitals have been full. My clinic got incredibly busy within a couple of weeks. People were comfortable coming back out. Things are changing again. Now it's harder to get those elective procedures done, and people are having a hard time necessarily getting care that they need at the moment.
Like you said, Rebecca, patients delayed care not only from a specialist or procedural standpoint, but from a primary care perspective. Just today, I saw a gentleman who had been lost to follow-up for over the past year and a half, and he came in thinking that he had a UTI because he was having excessive urination. Needless to say, his A1C was a 12.2, and he's a new diabetic. That should have been determined months ago. It looks like he might have some acute kidney injury associated with it or some underlying kidney problems. Those should correct with time and with medication, but it's not limited to procedures and being in and out of the hospital. It's just care in general. People are feeling more comfortable. For a period of months, we were doing greater than 10,000 telemedicine visits a month within St. Francis. That number's since backed off to around 3,000 or so. So it's still a high percentage, but not nearly the 80 to 90% that we were seeing in January of last year. Unfortunately, as Dr. Kriegsman said, hospital numbers are going up. It could potentially be harder to do procedures in the future for these elective surgeries. It's hard to forecast the future. I mean, I don't have a crystal ball, and mine would be cloudy if I did.
Well, those of you listening at home, I would like to hear your thoughts about telemedicine. So think about that. Send us some questions. I've had telemedicine experience. I expect you have as well. What is it like in primary care?
I started as a new physician in the middle of COVID. So I started with more than 50% video visits. I had to stop new patient video visits to build my practice. There was about 5 months when all I did was video visits with 2 in person. So I was seeing 99% video visits for about 3 months. But now it's great, I get to see some people again. I'm still doing about 2 to 3 video visits a day. But for me, it was an incredible tool to get access and help with care. But it's different.
It's definitely a tool for our toolbox, and there's a right time and a right patient to use that for. It's definitely not right all the time. Inherently, I think some patients are more inclined to want to do it. Surprisingly, the geriatric population, I think, was the highest utilizers. And I shouldn't have used the word geriatric, but, you'd think that there might be some sort of...
We'll call it those in elderhood.
Okay, yes, sir. A certain number of trips around the sun. Between FaceTime and Google Duo, we had very good success as far as keeping those patients looped in and keeping them out of the hospital when it came to heart failure or acute exacerbations of COPD or just diabetic management. So, I mean, like I said, I love seeing patients in office, but as far as routine follow-ups for, anxiety or depression or ADD management, things that a clinical exam is less advantageous, they're a great resource, and it enables patients to avoid having to take time out of their day, schedule off a block of 3 hours for work to go to their physician.
And St. Francis has another system I'd like you to comment on, where if you have certain symptoms, you can go into the computer, put in your symptoms. Talk about that. It's really a neat system.
I mean, do you even know about this yet?
E-visits?
Well, I mean, are you talking about e-visits?
Yeah.
Okay,
Yeah.
okay.
E-visits, I've had like 4, so.
Okay, so I actually sit on the Institute for Emerging Technology Physician Advisory Council. And with that, I was part of the group that developed e-visits prior to the pandemic, which actually gave us a good foothold as far as where to move in the future and where we thought things were headed. So we had a good groundwork even before the pandemic as far as how to leverage technology as far as primary care and care for individuals, just across the spectrum. The Warren Foundation was gracious enough to give us a $10 million grant, so we have, vast resources to expand this. And, not to pat my shoulder, but I actually developed the rash template for e-visits, the sinusitis visit for e-visits, and on a national level or even countrywide level, our COVID e-visit that we developed here at St. Francis, I think ended up in over 70 countries. I mean, it's just crazy.
Well, I think it's the future.
Yeah, I mean, it's definitely something that's pretty cool. And here soon enough, we're going to be implementing a chatbot within the St. Francis homepage to kind of help triage symptoms and get you to the right care at the right place for the right cost.
So the pandemic is giving folks an opportunity to talk to their doctors through e-visit, put in symptoms, small fee, goes right to you, you make a decision, comes right back, things happen.
It's a very limited, I mean, there's only, I think, 14 of them at this point in time. So it's not a across the board catch-all. I mean, there's, simple complaints, like you said, you can upload pictures for rashes, you can do UTI symptoms, sinusitis, the flu, things like that. So it's a very unique set of diagnoses where we felt safe that this would be we felt comfortable from a physician advisory board perspective that we would want to provide this care to patients, and we would do it from a medical legal standpoint where we were doing no harm.
Great. So patients want to be heard. They want to talk. You both have had some kind of social isolation, and your patients have too. There's touch deficiency on both sides. So when patients come in, how should patients talk to doctors? What will make a difference? How can we train ourselves to listen optimally? And how can patients bring into your office help us?
So my biggest advice on patients trying to figure out how to talk to their physician and how to get what they need out of their visit is talk to us like we're people. We're people, and we're there to help. We're not there to judge. We're not there to critique. We're not there to pass any judgment. We're there to help and to promote your health and to help you stay out of worsening health problems. I didn't say that very well, but basically talk to us as people and be honest. Makes the biggest difference.
I think that was said beautifully. I mean, it always surprises me when I see a patient and they comment about just how I talk to them like they were a human, and that I looked up, wasn't on the computer screen while I was talking to them. I paid them respect, and I guess that isn't across the board, which just blows my mind.
Well, some have set up a little what's called 3 Ps of being a powerful patient, and have a patient prepare and focus on being purposeful in the room, and then make things happen and be proactive after you see the doctor. What would you like patients to bring to be prepared for your visits?
Know the names of your medicines. That's a big one. Know the names of your medicines, and if you don't know them, bring them with you. And then another thing is try to keep track of places you've been before so we can get records.
Yeah, records is the biggest thing. I mean, that is one of the beauties of St. Francis is our health record, and just our notes go back to the starting of Epic, which I guess is in 2019 or 2009, I think. And so we have records that go back very far. All of our specialists and physicians across the board on all of our campuses use the same computer system. So if you've been seen once within St. Francis, we have some element of your record. If you were seen in the ER and you provided a medication list in, Muskogee, Oklahoma, I can see it here in Tulsa. So like she said, medication lists, records are incredibly important. If you're an established patient, and you're coming in for 6-month follow-up on blood pressure, bring a blood pressure log. If you're a heart failure patient and you're on diuretics and we're concerned about you being fluid overload, bring your daily weights. Just those resources are immensely helpful, or diabetic with blood sugar controls, as far as making medication adjustments in a safe manner so that we don't hurt the patient and we better their overall health outcomes.
Okay, so bring your records if you're a new patient.
Yeah.
Gather, bring in information, give you tools to work with because you have data, understanding, tests, and background. And bring your medicine. What I used to say in my practice was, I want to see every chemical you're putting in your body, and I don't care if you got a suitcase. Because right now, there's a lot of chemicals coming out of drugstores and coming out of various infomercials.
100%. And those are unregulated.
And those are all chemicals, and our body doesn't know. Body just has to deal with it. Do you like patients to prepare by bringing in a list of questions?
That can be helpful.
I think it's better for them to stay on point if they have something that they truly want to address and they get in there and inevitably they say, oh, I forgot what I really wanted to ask you about.
Right.
I always say, and this is kind of what you said as far as being proactive or following up, I always say shoot me a MyChart message, which is kind of like an email service within our EMR where it saves it as a medical record document. And I could say, hey, shoot me a message with your blood pressures after 2 weeks, checking them 1 to 2 times a day. And let me know that name of that blood pressure medicine that was started by, physician XYZ at, the Shoto ER, if they have an ER. And we'll make adjustments if we need to.
So for those of you who perhaps are not in the St. Francis system, this system called MyChart allows patients at home to do amazing things, including ask you questions, seek information. You could have a visit on Monday and Thursday you forgot to say, so you just bring it in. It all goes in the record, right? It's always part of things.
I use MyChart scheduling, so my patients can schedule directly through MyChart. I'm one of the pilots for the MyChart scheduling program. I do MyChart messaging, MyChart medication refills, and all my virtual video visits are purely through MyChart. I don't do any, the Google Duo or FaceTime wasn't set up easily, so I adopted MyChart very aggressively. And it's a wonderful tool.
And that's a lovely partnership.
And in the future, we're trying to actively increase MyChart utilization because that's definitely where the future is. We're working on rebuilding our app for MyChart within St. Francis, and we have certain metrics where we're trying to get more people logged in because it's an efficiency standpoint. From my perspective, if I can tell you what your lab work shows and tell you what we're going to do behind the scenes and not have to have somebody call you and have something lost in translation, that's immensely helpful. So, with MyChart, you're seeing your results in real time under a law that passed several years ago that just got implemented. You're actually seeing your results come to you faster than I can see them. Crazy.
New change, isn't it?
Yeah.
That's an inside joke, but until recently, we had to see the data first. So you wouldn't get surprised or scared by a number, an answer, a pathology report. But it's a freer communication now. The being purposeful, patient comes in with a series of questions, they have an agenda. But you walk in the door and you have an agenda. How do you work the agendas? How do you negotiate?
From my standpoint, I typically try to let everybody talk about what they want to talk about. I don't like to be that guy who says, hey, we can't talk about that today. Sometimes I'll try to, if it's a laundry list or if it's pretty intense, I might say, hey, pick up your top 5. But we'll try to hit them. If not, then we'll have them come back. But for the most part, I'm very liberal with time as far as what patients need. And I think most physicians are. We just want to help people.
Very similar sentiment.
So you both look at the patient's agenda, try to bring out the issues, bring out what they need. So that's a primary care approach. sharing primary, you're the important person in the room, but you do have an agenda.
Certainly.
Patient with diabetes may
Yeah.
need certain things, so.
Yeah, certainly we have an agenda, and certainly we're always pressed for time, but, you know, if you average it out, everybody gets the same amount of time. You know, it's just if somebody comes in and they recently lost a loved one, or if they're wanting to talk about something, I'm not gonna walk out of the room while they're crying to me. I mean, that's
Because
just-
your agenda can be delivered in other ways and later.
Yeah, I mean, there's always time to come back.
So what's happened to health maintenance? Well child exams, adult exams, and this Medicare wellness exam. And at some point, you got to explain what the Medicare wellness exam is. But this is health maintenance, and you're not seeing patients live. You're rebounding off need, but not looking into a preventive future.
So wellness visits are what I try to make the majority of my practice, is trying to catch people when they're well to keep them from being sick. So since I see children, well child checks start at 1 week of life and continue on pretty frequently for the first year of life, a little bit less the second year of life, then yearly thereafter through childhood. And that's there to catch their preventative vaccines, their developmental milestones, their growth curve, their weights, their heights, and to talk to parents so that they can have a chance to, this happened, is this normal?
Yeah.
Is this what's supposed to be going on? And after childhood, wellness visits morph very easily for women. They become well women exams, yearly starting at 21. And once we get to Medicare, it becomes your Medicare wellness exams, starting at 65, which is a yearly check into life.
So as far as your question, I mean, about the annual wellness visit, this may seem silly to people on the call, and it's silly to me too, but Medicare does not pay for a yearly physical. They will not allow you to go to your doctor for a quote yearly checkup. You can go there for acute complaints, you can go there for diabetic management, you can go there for your hypertension management, but you cannot go there simply to have a physical. This is a way for us to capture things that essentially take place at a physical, as far as things that can keep you out of the hospital, like pneumonia vaccination, shingles vaccination, CT lung cancer screening for people who have used nicotine in the past, AAA screening or abdominal aortic aneurysm screening for men 65 and over with a nicotine history. It's essentially guidelines put out by Medicare in order to save them money in the long run. That's what it boils down to. Technically, with an annual wellness visit, you don't even have to touch the patient. That's not how I think anybody practices, but in order to code for one, you don't have to.
I've kind of made them fun. We do our mental status exam,
Yeah.
depression screening. I take it as a chance to talk about life planning, advanced directives, talking to family, encouraging home health if we need it, working up those preventative pathways that you can't always catch on a diabetic visit. So I kind of like them.
Exactly. I mean, and it's a great resource for individuals as far as advanced directives, you know, knowing when, you know, potentially you want to have that conversation about a DNR, or, you know, who's going to take care of you in the event you had a stroke, or what your plan is. It's just those conversations that you don't get to have without some sort of prompting.
It sounds just perfect in a primary care role.
Yeah.
To be looking at issues from the heart and issues of mind and body, and where are we going? Give some thoughts, make some plans together.
Yeah, so really within St. Francis and Warren Clinic, we're really pushing for annual wellness visits as far as being something that we do once a year.
We dropped
across
the
board.
term annual physical, which is
Yeah.
an old term that needs to be dropped, and we're talking an annual wellness.
Mhm.
Well, what about a 50-year-old?
I mean,
Has a wife and kids in college, what does a 50-year-old should do?
So that's a yearly check. So the yearly physical term. Everyone 25 and up should have yearly screening for cholesterol, for blood pressure, additional screenings that come in, like what Dr. Hardy mentioned already, breast cancer screening, colon cancer screening, lung cancer screening, looking at pap smears as well as blood work should happen every year. The amount of healthy people that come in for their wellness visit where we find something preventable is large.
Yeah.
And if we catch things before they become an issue. That's the beauty of primary care and family medicine, is we can keep them from ever developing into something.
In my practice, I try to see every one of my patients once a year, whether or not they're on medicines or not. My practice is definitely an older population. I limit my pediatrics to 12 and over. But, if they're on medications, typically I'll do medication refills at the time of their preventative healthcare visit. If they're on, chronic blood pressure medicines and they're doing well, which gives me a chance to do basic blood work, or really appropriate blood work for screening purposes, as well as making sure that they're getting those markers met for colon cancer screening, prostate cancer screening, yearly mammogram, things that are missed if you don't go to the doctor. No matter where you stand on the political spectrum, the Affordable Care Act makes preventative care totally free. You can go to your doctor once a year for a physical, and there is no fee associated with it. So, that's something that really across the board, I feel like everybody should be utilizing, just to get a sense of where they stand on that spectrum of their health.
So that 50-year-old, a 45-year-old, we dropped the word physical, but it is looking for certain problems, measuring
It's a
blood
preventative healthcare
studies. There's elements of touch in a physical exam.
100%.
And you can use that then sometimes in an early detection into a flow of management that the patient may have no idea about.
It seems like every month, maybe not every month, maybe that's an overstep, but at least every 3 months, it seems like I've had a run of catching breast cancer just from yearly preventative screening where, they're looped into our system. We're actively ordering it. We're doing those things. And, several of them have been relatively young. In their early 40s. It's just very scary, the prevalence.
And that's a proactive health system approach of reaching out to bring women in. Talk about Pap tests, cervical cancer and breast cancer. There is an issue about Pap tests not being needed. Illuminate that for us.
So I follow the American College of OB/GYN recommendations and the American College of Cervical Cancer recommendations that Pap smear should not go away yet, in my opinion. Pap smears start at 21. They're every 3 years if they're normal until you're 30. Then they're every 5 years till 65. That's the basic guidelines. They change in between based on results of your tests and if you have symptoms. But on general, at least every 3 years for majority of women, we need to be doing Pap smears. Cervical cancer has dropped dramatically because of Gardasil vaccines. Back to preventative visits for kids. Getting the preventative vaccines in at a younger age make a big difference. But it's still important to have those screens every year. Our breast cancer screens, they start at 40. They go every year until the guideline is 75. My guideline is 75, or when you want to stop after 75.
That's kind of how I practice too. I have 90-year-old women who insist on getting it done, but I'm not going to tell them no.
And just the Gardasil that you mentioned, cervical cancer in a dominant way is caused by a viral infection.
Yes.
And Gardasil is a vaccine against virus. And I throw that out just because we are talking right now about viruses and vaccines, and cervical cancer has plummeted. And, recommended for girls
And boys.
and boys.
Everyone age basically under 25, between the ages of 12 and 25, should be vaccinated with Gardasil.
You can, I don't recall the specific guidelines, but I feel like you can even get it up to 40 now under certain situations.
If exposure is concerned.
Okay,
yeah.
okay.
What about the PSA test and prostate cancer? We're looking at early detection of breast cancer, cervical cancer, prostate cancer.
So the
floor is
PSA
yours, sir. PSA.
PSA, it's a great test. It's something that I do and recommend in anyone 50 and over. 45 and over if you have symptoms or a family history. And that's something too that we can follow with time. And it's a really, it's most advantageous where you have several levels to go off of. So then you can kind of trend it over time. And if you see a dramatic spike, that's incredibly concerning, at which time you'd refer to urology and likely set them up for a prostate biopsy. And that too is something that, we see regularly. I mean, if you're a man and you live long enough, odds are you're going to get prostate cancer.
And say again when you stop doing PSA in a man?
I'll keep trending it. I don't recall, is there a guideline as far as stopping?
Not really,
Okay.
because there's lots of argument guidelines for PSA. So
Yeah.
it's more, the actual guideline is patient dependent.
Yeah, I do them every year that I see a patient. That every patient who comes in for that annual wellness visit who's over 65, again, this is getting into coding, but Medicare won't pay for me to order a PSA for prostate specific, for prostate screening purposes. But if you have urinary hesitancy or difficulty voiding at night, I can order it with that code, and there I got it done.
Okay, so PSA is one of the conversations we talked about. This is a negotiation based on risk and dynamics and change. We only have 10 minutes left. This has been a wonderful. So I'm going to hit you now. You ready?
Ready.
Okay, patient comes in, could be any age, and the complaint is, I can't lose weight and I've tried everything.
You want to take this one or?
This is every day.
Yeah.
Every day. Very large, very complex complaint. Weight comes from a very complicated place, and weight loss is very multifactorial. It's food, it's hormone levels, it's age, and it can also be related to stress, physical activity, and other metabolic causes. Your thyroid, even sleep apnea can make you have difficulty losing weight. So when I have that patient, which is often, it's a large conversation and also a large workup. You have to rule out anything that can be making it difficult and then go down the difficult path of finding the solutions to help with weight loss.
To follow up on that, I mean, that's totally appropriate as far as what we do. As a physician, I mean, weight does have comorbidities and it will have long-term health outcomes associated with it. Osteoarthritis of the knee is resulting in total knee replacement, cardiovascular disease, diabetes, all these things are associated with obesity. There are several pharmacologic therapies that we can do to assist with weight loss, and there's something that they were kind of coming of age when I was in residency. It's something that I didn't really historically have any training on, but I use that in my practice now periodically for the right patient to assist with weight loss for a certain period of time. The thing is that insurance, for the most part, use weight as a cosmetic problem and not as a medical problem, which is incredibly unfortunate. Like I said, all these long-term health problems that come with obesity or morbid obesity essentially could be cured, and you could put a decade or more on your life in the right patient. I strongly advocate for patients with the resources financially or the insurance that's willing to pursue bariatric surgery. I mean, it's just such a life-changing thing for so many patients. It's just really hard to get it done.
It is impressive. Reversal of diabetes, elimination of blood pressure medications, a tremendous increase in functional capacity. You probably both are discouraged at seeing diabetes now diagnosed younger and younger, and the problem of obesity-related liver changes leading to liver failure in younger folks in their 30s. Okay, here's the second patient who comes in. I am not sleeping well, and I've tried everything.
I'll take the starting point on that one. The first time I see somebody, I'm going to counsel about sleep hygiene and things that we can do that are non-pharmacologic. I mean, I'm not wanting somebody who comes in to me with sleeping problems to go home on Ambien. I'm not sure that that's a good idea. There's a time and place for that patient if they have, stress related to a certain instance, or if, they've had, birth of a child and having a hard time getting back in a cycle after going through breastfeeding for the past year. So aside from that, essentially I'm going to recommend, hey, you need to avoid screen time, 2 hours before bedtime. You're not going to be allowed on your cell phone. You're not going to be allowed on your computer. You can't watch TV. And I'm not trying to be a mean guy. I'm just telling you that if you want to sleep, you need to do these things. Other things, you need to unwind. You need to not be listening to the news. You need to not be doing things that are not stressful. Maybe take a warm bath, maybe read a book. The bedroom should really only be used for sleep. I don't want you going in there and essentially playing or reading. Essentially spend your time outside of your bedroom. When you get tired or when you need to have a schedule. I didn't say that yet, but you need to have a schedule. You need to go to bed the same time each night and wake up the same time each morning. And same thing holds true on weekends. You need to avoid alcohol, caffeine, nicotine, any type of stimulant in the afternoon. And then if that doesn't work, I'm going to hand it over to Rebecca, and she can kind of talk about what she might do.
So if sleep hygiene fails, there are medication options for sleep. We need to also rule out sleep apnea and other things that can be causing you to have difficult sleep. It's a complex, multifactorial issue, and there are multiple different classes of medicines to help with sleep, and there's multiple reasons people can't sleep, so it's very patient dependent. So in that case, it's a conversation, like we've talked about, with the patient on why they can't sleep. If they're not able to fall asleep or they're not able to stay asleep, the kind of sleep hygiene they've tried. So it's a process.
Yeah, a tailored approach.
So, like a weight issue, complex, multiple things to think about. You start with ruling out, and then you individualize, and you begin this primary care approach of working like a team.
Yeah.
And the same thing with sleep. I should mention that, and by the way, your listing of the sleep hygiene was very complete. And it's nicely available on our friend Google. So emphasize, if you haven't heard that term or researched it, sleep hygiene is probably an 80% way to get better sleep. And yet it is.
It's incredibly important. I mean, your quality of life, if you're not getting good sleep, I know I get angry, or not angry, but maybe that was an overstep. My wife would say I'm not as pleasant if I'm not getting good sleep.
And Dr. Kriegsman, you mentioned sleep apnea. Give the audience a little sense of that.
So
You would think that'd be such an obvious thing, the patient would know all about it.
So sleep apnea is basically you're, for some reason, not getting oxygen while you're sleeping. You're either not breathing, or there's an obstruction, or something is making it so you're not getting enough oxygen. That alone is going to make you sleep 14 hours and wake up tired. Fall asleep during the day, doing dishes, sitting on the couch, you're just tired all the time. It can lead to hypertension, it can lead to kidney problems, it can lead to heart failure. It's a big deal, and it goes very underdiagnosed. And fixing sleep apnea with a CPAP, that's how it's treated, changes a lot of aspects of people's lives. So if you're tired all day long, it's something to talk to a physician about.
And that's something that can come up during a preventative healthcare visit, in the sense that, hey, I see that your tongue is rather large and your soft palate in the back of your throat is looks like it could be causing an obstruction. How do you feel at night? Do you feel like you're rested or if you sleep all night, do you feel like you're rested the next day? You can even show up on blood work with elevated hemoglobin and hematocrit levels, kind of like, I liken it to living on the side of a mountain where you're not getting good oxygenation. That's why athletes train at altitude, so then when they go to the Olympics, they can have a natural performance enhancer. So we can see those changes on laboratories.
So the man or woman with sleep apnea may not know how much they're snoring, how often they're choking up and can't breathe, how often they're waking up and rolling around, but the spouse and partner might. So this is a side question. What do you think about patients bringing in family?
Most of the time, it's very helpful. family can give a different perspective on a situation and can help advocate for a family member if they don't want to bring it up. There are sometimes patients don't want their family member there, and it is always patient driven. If the patient wants family there, they can be there. If the patient's like, I don't want them here, then they're not there.
I would agree with that immensely. I mean, if a family member wants to be there, or if they want to dial in on a phone call and be a part of the conversation even remotely, I always think it's beneficial to have two sets of ears listening, just so that nothing is lost in translation.
4 ears and 2 brains.
Yes.
You comfortable with that family member taking notes,
Yeah, I love it.
recording it?
I mean, that's a touchy topic. I mean, I don't know that that's come up yet. I mean, I know there's a lot of conversation about that in the medical community. I don't know if within St. Francis we have a stance on that. But I mean, that's something that I think I've been recorded before. I didn't have an issue with it, but at the same time, I just don't know. That's a good question.
I've been recorded before, and I prefer if you want to record that they ask.
I think that's a good, informed
Don't
consent.
secretly record me, but
Yeah.
if there's a difficult conversation or a difficult topic and you want to listen back, just tell me you want to record it beforehand.
We're just evolving communication at deeper and deeper levels, and there are issues.
Yeah.
Issues. So here is your last challenge. Third patient. Tired all the time.
It goes back to both weight and sleep apnea. Very similar workup, very similar plan. Tired all the time can be from multiple things. It can be depression. It's a very common way I diagnose depression is through fatigue. It can be sleep apnea. It can be from weight, lack of exercise. It can be
Hypothyroidism, hypotestosteronemia. I mean, there's a laundry list of conditions that could cause that complaint. The thing is that with medicine, you kind of have to start broad and then tailor and move towards that final diagnosis. And that fatigue is a hard one, and I'm sure in your practice it puzzled you at times, Dr. Piper. It's very challenging.
It is always a puzzle
Yes.
with many pieces. And you're right, you start with some of the big pieces.
I mean, if somebody comes in and they look as if they're prone to sleep apnea, you might get them set up with a sleep study as a first step. But I mean, it's individualized.
The mentioned depression with the pandemic. I've read that fatigue and tiredness from lack of exercise, lack of social contact, a chronic anxiety has a fatiguing effect on the body. Poor sleep has it. It's probably a lot more of an issue right now in our population than we realize. Is that reflected somewhat in what you're dealing with? Yeah.
very, very common.
I would agree with that.
Well, we have covered our questions from our lovely audience, and you've been wonderful. So thank you. Wish you all well. And thank you, audience, for following through. We will see you again as Medical Town Hall unfolds. Maybe we'll be in our beautiful new conference room. Thank you. Good evening.
Thank you.